Shall we do apologies? I don't think we can have any. Have we got any apologies, Tony? Okay. Yeah. Declarations of interest. I think the register has been updated now. Tell me if there's anything inaccurate on there or anything anyone wants to add particularly for this meeting.
No.
Happy? Happy? We're happy. Well, that is good news. And we are very correct. What did I want to say? I wanted to say that the board GPs, otherwise known as the board GPs, are doing the global challenge. And I've got a problem with Dr. Grewal, who hasn't entered his steps for 6 days and is letting the team down. And I think we're behind the pharmacists now. So, do you know, well, I assume that the chill pills are the pharmacists. I don't know that. It's all a bit anonymous, really. So this is the Virgin Global Challenge that people in the NHS and in many other organisations across the world are engaged in to try and kind of climb the Inca Trail and things like that virtually. So we're all walking around the place. Jonathan wants to know how many steps the 40-minute cycle is equivalent to. You know, this is engaging people. So is there anybody else involved in this apart from the GP?
Can I tell you why we know the children?
Go on then.
Because one of them, Jeff, pharmacist, cycled to Glasgow and did 250,000 steps. Just over 24 hours. So good luck.
I was going to say, this has really engaged our staff. We've got over 200 staff across South West London within the CCGs doing the Global Challenge, which is just fantastic. I think that's nearly all of them.
Yeah, so I'm very, very proud of everyone who's involved in this. It's a kind of an ongoing thing for 3 months, so you get your steps in, Dr. Grewal. Thank you. Jolly good. Right, shall we get on to some of the business? So
we're missing something, aren't we?
Yeah, I'm surprised our lay members aren't involved in the team, but yes, do join in. Minutes of the last meeting, which was the April meeting, because in May we had a seminar. So anything on accuracy? Thank you. And on the actions. So let's just go through, see what we've got here. Where's my action log gone? So first one, Sarah, on the Healthy London Partnership. So we were going to have a briefing on the homeless work. So that something went round.
So I've sent something round. And also have Tonia's said that if anyone would like to have more information, she'd be happy to come and talk to them.
No, but that was the briefing was good. Thank you. And on the budget and operating plan, what was that?
So there was a query about whether we were compliant with the IAP trajectory. On further investigation, we are indeed compliant. The NHS England view will be of us having a 4.75% rate of people entering treatment in Q4, which is what we plan to do, so we will be compliant.
Okay, that's excellent, thank you.
Can I just ask, the notes you sent round subsequent to the budget, there were those last minute adjustments. You send a note around to board members. Does that not need to be noted here? Not necessarily as a matter from this, but it arises post this meeting. So when would that be covered? Question.
Do I know what you're saying?
Yeah, I mean, my proposal would be that we note it with the first standing finance report when we get into the normal reporting cycle.
Okay. All right. Thank you, Chris. Good. Did I miss any actions on there? That was it. Great. Thank you very much. Thank you, Tony, for those minutes. So we'll go. Any items for AOB on the part 1 today? No. Very good. So annual accounts and report. You have the accounts and report in all their glory. Board members have already looked at these in a extraordinary board meeting. Julie, do you just want to help us out, comment on the process and what we might need to do today?
What we've done so far is we signed this off on the 22nd of May. We had a extraordinary audit committee followed by a governing body straight after. It wasn't a governing body in public, so we wanted to bring it back to a meeting in public. It's been submitted to NHS England already, and it needs to go onto the website by the 15th of June, and that will be the full report that we've got and that you've got here. We've brought it today just to have a bit of a discussion, if we would like to, about what should go into a summary report. We would normally pull together a brochure, a booklet for members of the public, just for it to be a bit more understandable for the public, rather than looking at all the 60 odd pages that we've currently got in the full report. There's some suggestions here in the paper as to what we might want to include in that summary, but it's really open for discussion if people have a preference of other things. It wasn't required to come here today because it's been to a governing body, but we just wanted to be quite transparent about it and give people the opportunity to say what we should summarise within it. I wasn't intending at all on going through the report again. What we've done is we've linked it to the refreshed operating plan. So the things that are here and suggested, some of them are areas that we know that we need to focus on going forwards. So we felt that that might be an area to start with as to what we did well, but what we need to put more emphasis on for the coming year.
Okay.
Yeah, so it was really, if people felt
so
quite strongly,
what we're really
we could.
looking for is about what should be in the
Yeah.
highlight report,
Yeah.
really. So, Chris.
The main document is a heavily prescribed format, and I think we've all agreed it's a pretty dense document. I mean, even for those of us charged with some responsibilities in the matter for the governing body. I think for the public, we need to have something covering each of the main sections. I don't think it should be so summarised that it becomes, 2 pages and it becomes so anemic as to be meaningless. I would suggest that you should be aiming for something no more than 10 or 12 pages and a succinct summary of each of the main substances in the report, drawing out what the main points are. And the best way, in my view, to ensure that the public understand it is to road test it with some members of the public. Does this make any sense to them?
So I was going to suggest with Sean that we take it to the patient and public group and see what they think and see if they think it's readable. We were gonna do that anyway, and we'll do the same with Merton.
Okay. Does anyone else have any comments on it? Julie, I just wanted to suggest that how we report on the George's RTT situation, in terms of the kind of further work to be done and the emphasis we're putting on it, but it may be, there's a risk it's relatively unintelligible to patients unless it's talked about in terms of waiting times, for example. So make sure the language that we use is intelligible on that. And then the other thing, I just thought it was probably worth highlighting on GP access, which I think has been a bit of a step change this year, really, and it is something that members of the public would be really interested in and would probably recognise as being important.
Okay.
Any other ideas or opinions on that?
We'll work with comms. We'll send something around to people when we're doing that summary anyway, but I'm not envisaging we'll bring it back here. No. But we'll have a glossy booklet for the AGM as well, which is where it's generally viewed more by the public.
Yeah. So, and our AGM is, have we got the date?
I think we've got a date in September. I can't remember the date off the top of my head, but it is later in the year. It's
so
not over the summer months.
Circulate that date to board members early so that people can make plans to be there if they're able to. That'd be good.
Is that right, Therese? It is September, isn't it? Yeah. Thank you.
Okay.
Thank you.
Excellent. Thank you. Very good. And I think all remains really for me to say thank you to all the people that contributed to everything that's in that report, i.e. the entire CCG team and all our stakeholders and partners and patients and people who've been involved, but also to the team that put it together, because it's a mammoth effort to do this, and particularly to James, who I know put a lot of effort into it, and Stephen, who has a fine tooth comb in his top pocket.
Thank you, Stephen.
On behalf of the management, I was just going to thank in particular the lay members for the input, because I know that it made it a hugely better document to have their detailed scrutiny review, and I know that they put a number of hours into that. So thank you.
Indeed, thank you very much.
Thanks.
Good. Okay. So next is the CCG 360 survey. So do you want to explain what this is?
Yeah, so on an annual basis we do a 360 survey, which is a survey where we ask stakeholders a series of questions about the working relationship with the CCG. we send it out to a list of stakeholders. Some of them are prescriptive we have to send out to, and some we can add locally that are people, that are stakeholders that we want to engage with on a local level. We sent it this year to 79 organisations, and I think we had a 62% response rate. It goes out to all of our practices, and then it goes out to many other different organisations. It does form part of our assurance framework, so actually the results that we get back are very important, and I think we probably need to do a little bit more with them than we have done so from the previous year. The results for Wandsworth are very favourable. The results have come back very, very positive. We had a score of 94% effectiveness in our relationships with people. I think there are some areas that we can do some work on, but the survey itself is split into 5 sections, and then there are various questions in each of those. It is voluntary for the organisations to respond, so we can't twist people's arms and force people to respond, and I think we've got to bear in mind that some organisations will get numerous requests from local CCGs, local organisations, CCGs. So, you know, our local ones in South West London, we've probably all sent that to each other. So it is a little time consuming at times for people to fill them out. However, I think if you look at the summary, you'll see that the overall responses and the answer to the questions is actually quite good. Some of them are a little bit less favourable than last year, but I think they're all of a good standard. They're all quite high in the way that there's been the feedback. So there isn't really anything that's fallen very, very low compared to last year, but there are some areas that have dropped a little bit. It's here for us to discuss and look at any thing that people want to say about how we can do that better next year, what needs to go into an action plan. But what's going to happen is it's going to be pulled across through the Alliance and have a plan for the whole of South West London, working with the comms team and with Louise Fleming, Director of Quality, to look at what actions need to be put in across South West London. We may obviously want to add things in locally for Wandsworth as well. I'm happy to take questions. I know we're going to have a discussion in part 2 because we get the standard responses, and then we do get some verbatim responses that we're going to be looking at later, and whether anyone wants to add anything.
James, anything to add?
Not from my perspective, but
Okay.
Sarah.
So I think it's always very easy, particularly when you've got a really good report, which Wandsworth has got a fantastic 360 survey response, I think, to focus on any part of it that maybe doesn't look quite as good as it did, or an individual may have responded. But overall, this is probably the best one in South West London, probably one of the better ones nationally. So I think, you know, Wandsworth do need to take heart from the fact that there will always be a few things in there that aren't as good as, you know, it was last year, or maybe slightly negative, but overall this is an excellent report, and it's a really positive reflection on Wandsworth, and I just think that's really important. Let's not forget that in the kind of slightly less, you know, having 94% instead of 96% is not the end of the world. So I think just bearing that in mind, I think it's a really, really positive report. So congratulations to all of those in Wandsworth involved in that.
Thank you. Chris?
Can I echo that? I think I would say as well that we've never seen ourselves as doing anything other than set ourselves high standards, but it's nice to hear the comparison. The only thing in here that slightly jarred with me was the second bullet point under plans and priorities. The first one is good, where people who were consulted are saying that they were effectively communicated with what we were planning to do, but the opportunity to influence what we were planning to do seems to have dropped down, and I think that is a marked difference. 71 to 63 is not a bit of a tweak. It's a 10% reduction in the perceptions of being able to influence our plans, and I think we just need to take heed of that. That's not in any way to detract from the overall report, which is absolutely... many commercial organisations and many other public bodies would give their eye teeth to have this sort of result on the 360, so I think we should keep all that in mind.
Yeah, just to respond to that, there are a couple of new questions that do relate to involving the patients and the public, and I don't know whether that's because that's lower because we haven't asked that question before around the patients and public. So we do need to be aware going forwards that that is now within this, and they are new questions this year.
James?
So I think that that's a really good point, and I think it's a very useful one to consider when we come and talk about the local health and care plans process, because I think what we'll want to do is make sure that we pick up and are appropriately engaging the full range of stakeholders in that, because that's our opportunity to really, in a very timely way, address that feedback.
So, Huda?
Again, I echo all the positive comments have been raised, but obviously I cannot not stop at the low response rate from Wandsworth Council, and also the nature of the responses. So what I need to say is that I think because we get these reports so frequently, it is sorry we missed that opportunity. I'm one of the culprits. I missed it this year. I always have commented on these. So the question is, what do we do with this information? How do we as stakeholders see, this is what you said, this is what happened as a result, so we can continue to be engaged. And also, I think the points is the granularity of the points I've raised are really important, and especially relate to children. We're in the middle of an Ofsted or towards the end of an Ofsted inspection. We really need to be objective and looking about what this is telling us, what we need to do better. But this is a conversation for us as partners rather than, a strategic discussion here.
Yeah. Okay. Stephen?
Yeah, I'm glad Huda raised that question, because that was the thing that stuck in my mind. It wasn't just that the response rate was poor, but actually the actual substantive response, insofar as there was one, was consistently negative. So I think there's something discussion to be had, as it were. Is there something actually going on there that we ought to be exploring? The other more general point was we do need to be careful. I haven't really got my head around this, the sample size. I mean, the sample size is predominantly GPs, if I got this right. So what we're getting into the aggregate statistics are giving great strong feedback about GPs, which is really important. But in a sense, we also need to balance off the other stakeholders, where the responses are by definition much smaller in terms of numbers. I think that's right.
I know Sarah wants to come in. The numbers are 79 organisations we wrote to. 42 of them will be GP practices. It's 42, isn't it, in Wandsworth? 40, so half now.
Yeah, in the back of the report, you can actually, it does specify individual groups, so you can tell what the response was by group. So we can be a little bit more specific around how we target in the future and make sure we engage. So where we have got negative areas, and I think on the council, what I would say is that's highlighted an issue, which I think is very important, but the fact that we haven't had a response rate does not necessarily mean that that's a negative relationship. I think that there's a very good relationship with the local authority in Wandsworth. I think that it just has passed people by, and I think that probably would have been some more positive responses if we had completion. But I do think that there has been something there highlighted which we will need to deal with. So.
Yeah. Okay. So. So Huda, I really welcome your kind of acknowledgement of that. I sort of echo what Sarah said in terms of, I think that there might be a myriad reasons why people didn't respond, and it's probably not because they wanted to give a negative response but felt they couldn't. It's probably because they're very, very busy, and it's probably what a lot of the organisations suffer from. I think that we've got a great opportunity now with the health and care plans, and just with the importance of the borough relationships between the CCG and the council, and a new council in place. It's a great time for us to make sure that we've got really strong relationships, that we're working well in the Health and Wellbeing Board and at the kind of operational level as well. That's the key for me. In some ways the 360 is kind of nice if it comes back positive. What's really, really important is that we feel that things are working well between the two organisations, and this is just one little marker of it, actually. And the other thing I'd like to say is I'm really grateful to Wandsworth GPs when they really are so up against it to be responding to a questionnaire like this, because they don't have to, and I think that's fantastic, and I want to do everything I can to make sure that we keep our GP membership on board, because we are our GP membership. And the final thing to say is about the communications versus the at engagement. So I think we're probably increasingly good at communicating with people. I think we need to stay good at engaging with people and work how to do that better. But I think the bit that people are really asking for is involvement and levels of influence in the organisation. Let's push it that bit further, because I think that's what will make the difference between us making good decisions and really good decisions. So just to summarise really what I think about that. Okay, so are we asked to note?
I think
Really?
so, yes.
Thank
I
you.
think ultimately there'll be a plan pulled together across the alliance, and whether we need to bring
Actually, I
that
just
back
wanted to
up.
check on that. So what is there across the alliance? Because I imagine, and we haven't seen all the other South West London CCGs stakeholder surveys. Is there enough common stuff that we can do?
So that's what they're doing at the moment, is working
Just
through
working
to
out.
identify if there are any themes. That much of it will be locally focused, but you've got to remember that even at South West London, we still have local teams working with the South West London team, so we'll make sure that we share but good practice. And Wandsworth was one of the better responses on the 360, but there's good practice across South West London that I'm sure we can learn from. So what we will try and do is focus some of that both at a local and at a South West London level.
Great, thank you very much for that. Right, now we're going to do local health and care plans update. So Josh.
Thank you. Okay, so just to give some context to the paper before I dive in. So, as many of you were aware, I think it came to the governing body. There was a update of the STP that came to a previous governing body, I think 3 or 4 months ago now. And what that recognised in the structure was that as a constituent member of the STP, that our local plans essentially are what makes the STP, and it had a much more local flavour. So it recognised that the vast majority of the delivery of what we need to do in order to ensure the good quality and sustainability of our services needs to be done at a borough level, and I think that was welcomed by everybody as a slightly different different emphasis, and the local health and care plan is the next step of that. So the first element of the paper talks about how it's being developed, and I think how it's being developed is almost as important as what is in it. It is being overseen in Wandsworth by the Wandsworth Health and Wellbeing Board. That is for 2 main reasons. One is to ensure there is genuinely a health and care plan. It's an integrated plan. It is isn't at all or perceived as an NHS-led thing that the care sector and other colleagues are just feeding into. And it also means there's some direct accountability, and we can work with voluntary sector, public and patients via that route. It's based on the approach that was outlined in the STP, that a local approach works best, that we want to focus around care around a person rather than organisations. And it should be around bottom-up planning and a focus on prevention. What's included in the local health and care plan? So there is some attempt to try and make the contents of all the local health and care plans across South West London consistent to some extent, so to make sure they cover the same sorts of things. The plan for Wandsworth will include a joint vision. It will address some of the key challenges. We've recently had the Wandsworth story refresh, which is a summary of the local JSNA that has been really useful for this piece of work. Articulates Health and Wellbeing Board priorities, and look at feedback with local people about services. That will then get built into a case for change. What do we think our main priorities for action are? What's our model for new services, and what difference will that make? In terms of what priorities have been identified in Wandsworth, as is often the case with a document like this, many priorities fall out. And what we have in the paper is when partners are asked what are the priorities you'd like to see reflected in the local health and care plan, there's a very long list. We are hoping that we can get this list down to a smaller number of areas which we think are particular priorities for really good quality joint working between agencies in Wandsworth. It's not to say that some of the things in here would be deprioritised as such, but it's just recognising the local health and care plan is where we articulate our joint work together. There'll be many, many other things that each partner are doing as well that also contribute to the sustainability of the system. Though I think, but this is, I guess, for comment and discussion, those will be reflected in the plan, but won't be the thing that's front and centre centre of what's in the final document. I won't go through all the areas because I only have 10 minutes, and we'll be here all day. In order to help make the decision about what goes into the final plan, service leads, service commissioners have been asked to pull together summaries against all of these areas that basically answer 4 questions. So how do we know this is an area of need? What's our current strategy to address that need? What are the actions we're going to take, and what do we think the impact of the current strategy is? That is being looked at by the Health and Wellbeing Board Executive and will be discussed, I think that's right, James, at the next Health and Wellbeing Board in end of June. That's right, end of June. So that's probably what I just say in summary for the document. What I'm looking for here is, it says it's an update, but also for comment, steer and discussion. The next steps are, we're hoping over June and July that we can determine the priorities and what goes into the plan. August is then writing the thing and getting that right and writing it in the right way so it's an accessible document that's a call to action and not something too dry. Then engagement around incorporating further feedback into the delivery plan, and then with a final published date around November sort of time. So I'll end there and happily take any questions or comments.
Good, thank you very much, Josh. So, Stephen.
Thanks very much, Josh, and I'm very happy with basically what you proposed. I guess my question is whether there is a big story here, as well as the sort of relative incremental, we can do a bit more here and a bit more there and a bit more wherever. And in my mind, this is really a question, in my mind the big story has been about what is going to happen in the foreseeable future in terms of demand? In other words, what's happening to the population and the people at risk, particularly, I guess, young people and older people, but other risk groups. In other words, is there more of this in Wandsworth, or is it flat, or is it a big increase or small incremental? And then in macro terms, what is our response? And in particular, are we or are we not attempting to shift the focus, as it were, upstream or downstream, whichever way around it works? Because the story across the NHS for many years has been that actually to get to sustainability, both on clinical grounds and financial grounds, we have to do less, in effect, in hospitals and more in the community, in prevention, in social services, etc., etc. But that story, is really hard. We don't really articulate it. We don't put it in terms of numbers, by which I mean people, not just money. Yeah. And what is the shift? That is this real or is it rhetorical? Are we actually going to see more people? Fewer people going to be having hospital services in future? Do we really think we can make that shift, or is it that hospitals will grow a little bit less fast than other services? I think there's a bit of a picture here about what the nature of the is this, is it making, is there a big story going on here, or is it a lot of relatively modest, important, and very important, but ultimately rather incremental changes to this service and that service in a bottom-up sort of way? And I think that's the bit I'm sort of groping for. Have we got a big story?
Okay. So my response to that, others may have a view given the things we're working on at the moment, is that we have an annual round where a lot of what we do in our commissioning intentions is by definition incremental. It's building on strategies we're already working on, services we already commission, improving them, and that, as you rightly say, makes a huge impact. I think the opportunity around the local health and care plan, I think, is to grasp and put some real structure about some of those more upstream type initiatives, pieces of work to look at the demand that we're seeing. My own personal expectation is that as a result of the work we're doing, we would see a change in the share of how our funding works. So you would see over time, smaller proportion of spend, obviously acknowledging the budget may go up or down, on acute care, but that to be done not as an end in itself, but because we've been able to develop community services, preventative services and elsewhere to manage some of that demand. I think if what you're getting at in the local health and care plan is should we articulate that up front and quite clearly, I think absolutely we should be saying that that's how things will look differently as a result. I think the ongoing discussion around prevention has come through really clear in these discussions because they involve so many different partners. A meeting with the Health and Wellbeing Board's engagement group yesterday, and that was a voluntary sector engagement group rather, and that was a big theme in what they were saying is they could see a huge amount of potential in discussing a small number of areas that were genuinely collaborative across all partners. We do a lot of collaboration, bilateral or trilateral, but where everyone is involved, we could really move some things forward.
Okay, James.
So I mean, I think that I think that's absolutely right in terms of the way that a lot of the detail does actually achieve those effects, and it's actually about understanding the constraints that we're trying to address at a very detailed level and how we're going to address them. I would also highlight that this process follows on from the South West London Health and Care Partnership 1 year on document that we published late last year, which did articulate how the overall gap, if you like, we'd refresh that analysis in terms of the gap in terms of money and in terms of future capacity. So it is responding to that South West London sector-wide challenge in terms of the gap, and this is in a sense part of the picture of that response, because this is about the local borough level responses to part of that gap. There are also sector-wide responses to part of that gap as well. So I think that what will be important with this is articulating the role of the Wandsworth Local Health and Care Plan within the overall South West London health and care response to that gap, because it doesn't sort of sit neatly within a borough boundary. The other thing that we're trying to do with that gap is really try and understand the health and care elements to it, because often it's been quite difficult to quantify what the gaps are on the social care side, and we know that we need to address those equally, because even from a sort of parochial NHS perspective, if we don't address those, then that has a knock-on effect on us. So I think it's absolutely right. I think we need to articulate it up front, but we are, this process is a part and not the whole of the response to that.
Yeah, I think that's fine. I do think I would quite like to know, when we get to the end, I mean, whether, for example, are more people or fewer people activity, not just money, going to be in hospitals, in primary care, in wherever. I think I would get to money. Money is really clearly very, very important. But I think a picture of what is happening to people in the first place, and then what are the financial implications.
Okay. Yeah. So, James or Sarah, are you going to say the same thing?
So no, I was going to say thanks. So I think that there is. So this is a kind of continuum almost. So there's a South West London piece of work that says actually we're all going to work together across South West London in a different way, and there are very sort of specialist tertiary services that we're going to work on outside of South West London. There's stuff that we're going to do at a South West London level. There is work that needs to be done across what I would call a complex system, which includes our providers and others. There is work that needs to be done at a borough level that includes the primary care at scale, local communities working together in networks, and how that is delivered. I think we need to articulate that in a way that makes sense locally. So I see this as a first step in identifying some of those needs, but I think it's wrapped up in networks within a borough that then deliver improved outcomes for patients, which includes the activity associated with that and the money associated with that. And I think what we need to make sure is that we can get the continuum right. So I think we need to make sure the complex system bit works, so what goes in and out of hospital and what stays in the community. There is a danger of us going too far NHS or too far is all about care, and we need to get the balance right. So we need to but I think one of the main things is, can we articulate that vision in a way that makes sense? And I think what this does is a starting point in kind of listing all the areas that have come out through the JSNA. I think what this needs to get to will be a clear articulation of the borough networks model and what that then means for providers and how that links into a South West London piece of work. So I think it's a first step would be my view, but I think it will need to progress into that. So I don't know if that helps, but I think it's not there at the moment. I think you're right. I think we need to get it there.
Okay. James, then Chris.
I mean, just to build on that really, because I mean, this is getting into more sort of practical sort of issues. One of the things we were talking about earlier this week, and we'll look to build into this process, is how you link that patient or person through the money and the capacity and the activity, and it's how you don't lose the patient when you change them from one setting to another. So we were talking earlier this week about how we can make sure, whether you call it bed equivalents or outpatient equivalents, how we track that activity through so that we make sure that we can cost it, make sure that it does work through in capacity, and you can then link it through the whole system, because as you say, Sarah said, we've also got, you know, areas where other providers are looking system-wide as well as just looking locally within the borough. So it is quite a complex thing, but it is something that we'll try and track that through.
I mean, can I add just
Josh,
so, I mean,
yeah.
in many of our plans, particularly when we're looking to support a reduction in pressure on the acute sector, that the money is derived from an analysis of the movement of the patient. So we should be able to articulate within a reasonable amount of detail what those expectations look like over time, because we've made financial assumptions on that basis. So yes, I think if what I'm implying from the comment is that the plan needs to really articulate what that looks like on both sides of that equation, then yeah, that's really good feedback.
Mike, is it on this? Oh, okay. Chris.
In a sense, everything everybody said makes absolute sense, but I think Stephen's key point is actually quite an important one, which we need to sort of keep at the back of our minds. These broad headings of people starting life with maximum opportunity for good health, living well with maximum opportunity for good health, and ageing well. It ought to be possible, if this plan passes the common sense test, to say over a period of time, of the things we are planning to do, we are intending to enable better starts, better living and better ageing. Now, in a way, that doesn't need to be a report like this. It needs to be a series of really punchy initiatives in plain English that anyone can understand, that we are going to use our resources and our efforts with partners to improve each of those standings. So I think that's where Stephen's absolutely right. There is a big story here, and we need to make sure we don't lose the big story in a series of incremental line adjustments, which will be the way in which we make it happen, but we need to be clear what it is we're trying to do.
Yeah, I agree entirely with that.
So let me just give people a heads up. So in a minute I'm going to ask GP colleagues about, just from a GP point of view, what would our membership say about this approach and maybe this list of things, or just give you the opportunity to just have a think about that. James, was that on this, following on? Go on.
I think that what we're always very aware of is the risk of verbosity and impenetrability around when we write these plans. So that's why we've gone through this process of basically identifying, and it is literally on one page, how do we know something's an area of need, what's our current strategy, what are we doing, and what impact is it going to have, so that we can actually develop, as you say, those incredibly clear metrics where we can say, well, what's going to be the impact on people, and then then it's that impact on people, as both James and Josh have said, that allows us to build up the analysis of how it changes the pattern of use of the system, rather than sort of starting with the change of the pattern of use of the system that you need and then trying to kind of retrofit analyses to it, which is, I think, where these processes have possibly had a few challenges in the past.
Yeah, okay. I'm also going to ask Jamie and Huda to comment in a minute on this. So, Mike, you were waiting patiently.
Yeah, so I'm going to comment as a GP first, and I'll say that I think our GP members, certainly in Wandle where I work, would be very supportive of these. They'd be particularly happy to see mental health featuring heavily in the Start Well and Age Well. They may be surprised that mental health isn't, other than suicide, and integration doesn't feature quite as heavily in the Live Well section. Again, as a GP, I guess you could argue that everything is in this list. So you've got children, adults, hospital and primary care. That's kind of everything, really. What I was going to ask, and so the question I was going to ask is, and it may be more for organisational memory, and maybe Huda may have something to add here, but I just wonder whether we, looking at this, think that anything's dropped off our kind of priority list over the last couple of years. An example I would give is certainly 5 to 10 years ago, teenage pregnancies would have featured as a key line here, which we've done really well with, and no longer feature as a key line. Just wonder whether we felt as a board that anything significant has dropped off the list from a couple of years ago. I can't think of anything.
I know about one.
Go on then.
Smoking cessation. So I think that when we looked at this list, I think smoking cessation had actually been a priority the previous time that we'd done this sort of planning, and actually we're sort of tracking now, and we're at that kind of residual level of adult smoking that you see in many areas. So I don't know whether it's right or not, but the analysis would support that.
It may come into prevention.
Yeah, but
So,
as a discrete item,
yeah.
that had been a priority in the past.
Can I just come back on that? So yeah, actually, now that you mentioned it, I recognise that was a heavy feature for certainly the last 5 years of our priorities. What I was also going to add is how pleased I am to see that looking at this list, this very closely matches what I hear as priorities in the Health and Wellbeing Board and also in the Public Health Board. So it's great to see our partner agencies' priorities really featuring so strongly.
I think there might be one thing missing from the point of view of age well is our care homes, where work across health and social care could be really, really important, and we might need to have a look at that. So anything from other GP colleagues? Jonathan?
Yeah, no, I think Battersea GPs would, I mean, like Mike's saying, it does seem to cover everything, but I would agree care homes needs to be a priority. I'm very mindful that when one of the roadshows we have in Battersea, one of our patients challenged us about priorities we have. I can see that we need priorities, but the perception of priorities from a patient point of view, maybe a better word is things that need particular attention, because if you've got a condition that doesn't appear on this list, does that mean you're not a priority or not valued? So that's just an aside, but some people it's very useful to see how the list has been achieved and whether it's sort of the story is that these are things that we particularly need to pay attention to because there's a particular need, not that they're prioritised over everything else.
So I think the answer to that we'll need to articulate is that yes, they are things where there's significant evidence that there is a need. They're also things that we need to work on together with all the partners to the local health and care plan.
Yeah.
So there may be things that one or two agencies could do a huge amount of work on, but don't necessarily require the full partnership to work on. The fact that my response was a little bit clunky to that question, though, means it does need to be refined for the document, and I think it goes back to Sarah's point about how does this plan fit in with everything else and how it's laid.
Okay, so I'm going to go Huda, Sam, Jamie. Huda.
So first of all, we're working very closely with Josh on this one, so it's not a surprise to us what's here. Given what Sarah said about, how this complements and James, I think it's also important to, if we look at the total picture, what the local authority is doing around determinants of health, around housing, improving the environment, employment. There is a kind of really big story also happening alongside this. So if we articulate a system-wide thing, we need to capture that. I totally support the 3 stages that you talked about, Chris, but would adequate health inequalities as well. And already I've spoken to Josh now. I have a list that I can, we have a very, very clear strategic bullet points that we can include that I've been agreed nationally around this, so we can include this. If Liz Bruce was here or Dawn were here, they will definitely want to put the argument around the pressures on the services and the funding for the services. It's really unprecedented, as you know. And again, this is combined with ever decreasing grant on the public health grant. There is a national decrease, and when the ring fence is removed in 1 year, then it will be very difficult to kind of see how we can square the finances and there. So again, this requires a conversation amongst us and the Health and Wellbeing Board.
Okay.
In terms of what has dropped off, I think these are the points have been covered. I can't think of anything else off the top of my head at the moment.
Thank you. Sam?
Yes, just sort of following on from that, really. I think for me, when I'm looking at this, and obviously these are just literally a headline and there's very much that sits behind it, but it's the thread of prevention that needs to come through. So suicide is obviously suicide prevention, and prevention actually, and that actually links to what's happening in CAMHS and how that's articulated as a kind of starting point, because clearly that is a starting point from the Health and Wellbeing Board, is that this is driven by an approach of prevention, and I guess that would be really good to be able to see that running through, not just as a separate section with smoking cessation or other interventions, but how prevention underpins most of these areas, and that's articulated as kind of up front of how is that we're coming at that across the partnership.
So I think when we had our Health and Wellbeing Board initial discussion on this, we sort of looked at it in terms of a matrix. It ended up, in my head, being a bit like a Rubik's Cube, and I can't remember what all the parameters were, but it was start well, live well, age well. Prevention, I think it was prevention and kind of clinical management, and then care or something like that, and then it was looking at primary, secondary, community or something like that. So we had to make sure you're kind of covering off every angle of everything, and it looked a bit complicated, so it might not appear in the actual document, but it might be a helpful kind of structural framework for thinking about, are we getting all the right important things in here? So
can I just respond to that? So I think I absolutely agree, and I think it needs to be all the way through and not in a separate section. There may be some bits of work that are of the scale and importance that they have some focus, but I agree. I think that's going to be really important to get that right in the vision bit right at the beginning, and then have that thread all the way through.
Yeah.
But thank you.
Great. Andy. So Jamie next, and then Andy.
Thank you. Just leading on from James's thoughts, it sounds like engagement might be really important. Josh mentioned engagement probably in the autumn. I just wondered if you had any thoughts on that, or is it really down to the Health and Wellbeing Board?
Can I come back on that one directly, if that's all right? I mean, I think so the engagement's really important around this, but equally it's about being able to articulate what as a consequence of the local health and care plan is different for people. We know that a lot of the work that we've done, a lot of the strategies that we have, both ourselves and our partners, have had extensive engagement, and that we engage all the time as part of those processes. And I think it's probably fair to say, Sarah, across the Health and Care Partnership, we've been keen to not engage on the process of producing a plan for the sake of a plan's sake, in a sense, but actually to engage on what will be different for people. So I think that we need to make sure that we're using a lot of the engagement that we've been doing for many years around these areas, and in a sense, when we have something to say about what will be different from the LHCP, then we'll need to be really clear about articulating that. I mean, I'd definitely welcome feedback on that, because we're not kind of making a specific effort around the process in a sense, but it's I'm aware of a certain amount of plan fatigue, I suppose, and I think we all are, and we wanted to reflect that in the approach.
Yeah, Carol.
I agree with Jamie about the need for engagement, but I think it is perhaps better focused on some of the subsets of the plan. The plan itself is just, high level, but I think a focus on starting well or living well or aging well, or indeed on some of these sub-themes, perhaps prevention, much more likely to evoke interest and active engagement and involvement in developing some of the sub-processes of how this works. I think the plan is with great respect to those writing it, may be seen by some as pretty dry.
Yeah, I can take that as a personal challenge to try and improve on that. I mean, just for some reassurance, at the voluntary sector engagement group yesterday, they made exactly the same point, which was that there are various iterations of public sector-led planning documents. They did welcome that there was an effort to engage the full sector, including the voluntary sector, in that right at the get-go, but that the sort of the usefulness of the engagement will be in the detail.
I think it's really important to include the voluntary sector throughout all this.
And Jamie, just I think so. We would, I think, welcome suggestions from Health Watch about specific things that you would like to see, make sure are done. So you're always welcome to write to myself, Carol, and make those suggestions. Having discussed it with your Health Watch crew, that would be excellent.
Okay, can I just come back with one thought?
Yeah, sure.
Carol, yes, it will be a high-level plan, but it's a Wandsworth plan. That's the beauty of it. Local people like local plans.
Yes, I think that's
Don't
a good
lose
point. Okay, I'm going to run out of time here. Andy's been waiting patiently. Sarah, were you going to comment on that, or can I leave that?
I was just going to say that it's important that it's not just through the Health and Wellbeing Board, because I think the implications of the Health and Care Plan is wider than just the members of the Health and Wellbeing Board. So I think it's important that we do lots of engagement and working with all the systems.
Is the engagement going to be driven by the Health and Wellbeing Board?
Yeah.
But actually, we should.
What I'm saying is it should be, the CCG should be making sure that it's much wider than that, is what I'm saying.
So absolute final one, Andy.
Thank you very much. So just in the context of framing it and making sure that this is not a fatigue plan, or whatever the phrase James used was, I think it's really important that we pick areas that we actually do better together with, because it's a health and care plan. Because I'm looking at this and I'm also thinking childhood obesity, asthma, you can go through about 150 different ones. And then I think Nicola mentioned care homes, which is actually something that I think we can all do together. Falls is something I know we had a big focus on over the last few years. We did a good joint piece of work on that. So I think the framing of this in the context of, well, this is areas we can do together, is the most important thing. Otherwise, we can still be here forever and a day doing bits and pieces separately.
Good, excellent. Thank you. I think that's a good place to round this up. So, I think the board has done somewhat more than just note the report. Josh, I hope we've...
No, well, I said that up
helped you with
front.
a bit.
That was
Yeah,
exactly what I was
thank you.
after. Thank you very much.
Good, excellent. Thank you for that discussion, everyone. So, James, are you going to talk about this bit? Yeah, the next bit.
So this really came about from a number of sort of discussions around
how we could look at using our committee structure across the CCGs a little bit differently as we move forward. And the two that we focused on were audit and finance committees. Initially, we had a sort of morning out with our audit chairs to go through how we may look at some of these issues from an audit perspective, and I can update on that in a little bit. And we also had a bit more of a disjointed affair with the finance committee chairs, but I have spoken to all of them, and we will get them together in one room. But we had a good concept discussion with all finance chairs, and the aims really were to see where we can work together across either the 5 or 6 CCGs, looking at different models around how we could get some better consistency of approach and look at where we could align some of those, pull some of our knowledge and skills and capacity, and also, as we picked up a bit with the 360 review, see where we can learn from each other and try and drive all of ourselves up to the higher echelons of where we want to be. So the audit meeting was facilitated by Deloitte for a morning, and we had a good sort of wide discussion on that. And I think the key sort of things that came out of that were, yes, people could see the benefits of holding a number of committees in common through exactly what I've just said in terms of avoiding some of the duplication, some of the system working, and how we review things. But there was a real keenness that we don't lose that local focus, and that we have sufficient time in both audit committees and finance committees to look at the local issues and make sure that we've got that assurance coming back to the individual governing bodies, because although we're working as a system, we still have to bring things back to our governing bodies. The finance committee chairs had similar sorts of views on that. There are some nuances in terms of differences on that. But I think in both of them, the chairs came to a conclusion on both of them that there is advantage to doing that. I think for both audit and finance committee, we're looking to see whether we can develop a structure that would probably have alternate meetings. So you have a local meeting 1 month or one audit committee, followed by a system meeting in common following that. So it will give a sense of actually managing things both as a system, but also hopefully giving time to manage things locally as well. That was the kind of coming thoughts from the chairs. Taking them both forward from that, obviously we'll need to bring this back as a formal sort of proposal. The audit chairs are going to meet in September with their local committees to take that through their local committees and agree how exactly we would work that. So, and then we would look to have a sort of first meeting subject to approval in November as a system meeting, and then it would be alternate from there on after. With the Finance Committee chairs, we try and get together at the end of June, because there is some stuff that we need to look at fairly quickly around some of the system finances and the STP processes, to look at how we bring that together, and we'll do the same really. So we'll have a similar approach where we get the finance committees together individually to work through that, make sure that everybody's content, and we'll come back with a proposal that comes back to governing bodies. We can update formally when we've got all governing bodies meeting in early July, but we'll look to do that through hopefully get that signed off and approved in September. But I think it'll give us a lot of opportunity, particularly around some of the things, even things like the local healthcare plans, how we approach some of the planning going forward. It'll give us a big opportunity, I think, to have a much more streamlined way of working for that. I don't know whether either of the chairs who have been involved in those conversations want to add anything to that.
I think there is one important point. The South West London Alliance is effectively a federation of statutory bodies. So whatever arrangements are made to operate certain activities, certain committees, certain functions in common, that has to be set in the context of this federal structure. The alliance has no statutory basis in law, and ultimately is not accountable in law because it doesn't exist in law. So we have to square the circle here. And I don't think that this is in any way trying to frustrate or not make sensible progress. But we have to reconcile the statutory basis of the CCGs with this federal structure. Yeah. That, I think, is the challenge. I think we can all see it's going to make a lot of sense to operate as far as we can in common. What I would be resistant to is the notion that somehow it's possible to run the finances of the alliance by simply getting the chairs of the committees together, because I don't think that can be squared with the ultimate governing body responsibility in law. So that would be my sort of bottom line. My red line in the sand, if you like, would be we can't do it like that. That doesn't square the circle. Stephen may have other views on audit, but that's my view on finance.
Stephen, it would be helpful to hear.
Yeah, I mean, I think I agree with everything you said. I mean, I think there is a need to do something like this. My worry has been, it's a particular Wandsworth concern, that, putting it negatively, we are the host for the activity going under the rubric of the Alliance and the rubric of the STP, which are not identical but do overlap a bit. And it has worried me for some time that, putting it negatively, if something went badly wrong, as it were, where would the finger of blame be put? And it could be all over the place.
Probably here.
Probably, yes. But actually,
we rather thought that as well.
but despite our best endeavours to switch the blame over there, actually the chair of Wandsworth Audit could also be in the frame, and I do think that there is a gap in the moment that we haven't got satisfactory. So I'm as well as the committee structures, I think what's really going to be really important is to have it written down very clearly, what are the processes and what is the authorisation processes, through the cycle of Alliance and STP stuff, from, original budget setting, planning, that thing, through control, through to accountability, audit, including VFM challenge, whose job is it to say, hang on a minute, not just does the numbers add up, but is this sensible, etc., in the way that we would do, and ask, and if necessary, ask internal audit to take a look at things. And I think the more we can both have a committee structure, a governance structure, absolutely reporting back into the statutory bodies, but with this clearly articulated, so we all know what the rules of the game are, then I think we'll all sleep much better at night. I think that would help all of us.
Sarah?
So just to say that I share Stephen's concern around the accountability, obviously as I would as a council officer, and I think we absolutely need to do this to ensure that this happens in a way that makes sense. There is no intention whatsoever to undermine the statutory accountability of individual organisations, and this will be about how do we square the circle to make all of this work. And I need to thank the lay members that have been involved in this, because they have come in and given their wisdom and their knowledge to the process to get us here. And I hope that we will continue to work sort of in partnership across South West London with everyone to get us to the right place. So we will make sure we go through the right statutory governance, and we will make sure that we do this in a way that makes sense for everyone. There is potential for this to be a huge amount of learning, I think, across South West London, as well as looking at the statutory responsibilities. So there are potential for us to get added benefits from this, as well as the ones that initially brought us together, I think.
Okay, thank you. All really helpful. So I'm pretty sure that will be a temporary, transient arrangement between what went before and whatever it is that comes next, which I won't attempt to define. So that's fine. So there's an issue there about, so firstly, will all the work get done? And secondly, how much double running will there be? How many times we'll have the same conversation twice in 2 different meetings, etc. So, and notwithstanding who's going to go to jail for what, I think it's really important that this board gets its finance committee and its audit committee reports, and we can utterly rely on them, and knowing that the other and very closely related world of the Alliance and the STP are also being furnished with the right kind of finance and audit expertise that we need to make sure all the collaboration goes right. So, is there physically, whatever the practical, physically enough time, enough meetings, enough lay member capacity to do this? Have you counted how many meetings there are in the calendar to enable this to happen?
So the intention is not to increase the number of meetings at all. It is just to alternate, and it will still allow for local discussions to happen within that if it needs to happen urgently. So we will make sure that, and actually if we don't need a South West London meeting for any reason, we can just turn it back into a local meeting. So it should be the same amount of time. What we shouldn't be doing is duplicating, the idea is we do it once. Yeah. So then, and the only thing I would say is there may be times where, and with this where we'll need to test it and trial it out and see, and we will review it, is lay members may think, actually I'm sitting through this and it's about Sutton and this has nothing to do with me. If we're finding that is useful and it's, useful learning, then we'll carry on. But if it's not, then we can stop those parts and just have those individually. So I think there's ways around it. I think we need to make sure that it isn't an added burden, and we need to make sure it works in a way that makes sense for everybody. Yeah. So there's definitely no intention to kind of duplicate.
No, I understand. So I think really what I would want to hear is sort of a close watching brief, really. Yes. I think you might call it, on progress, and for concerns to be raised about that we don't seem to be having the capacity to get the normal business as usual, the stuff that has to be done. So, Chris and Stephen, I'll really rely on you for that. Chris?
Can I just make one other point, which I think is really important as this process, this transition, this interim, whatever you want to call it, move. The huge strength of the CCG structure is the active engagement of GPs. Yeah. Yeah. And we really mustn't throw that baby out with the new bathwater. So I think that's critical. That would be my point. Absolutely critical.
So just on that, one of the recommendations coming out is that because it's a smaller number of people coming from each committee to the committee in common, that one of those is definitely a GP from each area, which means that ultimately you'll have 5 or 6 GPs in the room in the finance committee. For audit, that's slightly different, and the recommendation is that that it's not necessary to have GPs in the room for that, and that's mainly because the view and the discussion that I've had with many people is actually audit is about checking process and governance. It's not about the detail of what's going on the ground, and therefore we actually don't need and wouldn't want to have valuable GP time spent in that way. And actually that's more for the lay members and those involved in the governance.
I agree. Good. Okay, James?
Yeah, just one final point on this, which is just a bit of a nuance. So Croydon obviously don't sit within the South West London Alliance. We only met with the audit chairs of the Alliance, but there was an invitation to go to Croydon to invite them to this process. For finance chairs, we did involve Croydon, and it will involve all 6. So just a nuance on that. So.
Yeah. Okay, excellent. Thank you for all of that work and thinking that's gone into that. So that's noted by the committee. Did we have to do anything other than just note? Was it just noting what's going on? It's coming back. Yeah, good, thank you. Okay, shall we go on to our clinical focus area, which is on Emergency Care Delivery Board overview and the winter review. So, John, are you doing a double act with Sean? Or are you
yeah, it's a double act with Sean.
Do you want to come in a bit closer and perhaps could you introduce yourself? Because we won't know you. Well, they do, I do.
Hi, so I'm Sean Stone. I'm the Interim Director of System Resilience and Transformation for NEL CSU, but we're focused on Merton and Wandsworth.
Good, thank you. John, do you want to kick off?
Thank you. The paper we've brought today brings together 2 key themes. It gives an overview of what the Emergency Care Delivery Board has been doing for a period of time, and now winter has finally ended, and we've got a couple of clear months from the pressures, the winter pressures. It provides an opportune moment for us to look back at what went well over winter and the challenges we faced. Sean's role in particular has had a significant focus on winter planning and mitigating some of the winter pressures over the last several months. So Sean will talk to most of the slides around the winter period and what went well, what didn't go well, and what we're doing going forward to ensure we've got the best possible plans in place for winter 2018 and 19. But I just want to begin really by introducing what the Emergency Care Delivery Board does and where it comes from. For a number of years, commissioners in their various forms and provider trusts have had some sort of meeting where they talk about what they're doing around pressures in A&E and sometimes the wider system. Bruce Keogh back in 2013 initiated a piece of work which then went on for a number of subsequent years, looking at urgent and emergency care and looking at opportunities to transform and improve the way in which patients accessing care through that route were being treated. Most recently, what's come from that is a 7-pillar approach to fundamental areas of that care that we need to look at. And for Merton and Wandsworth, that has been reviewed through the Emergency Care Delivery Board, and very consciously titled the Emergency Care Delivery Board, not the A&E Delivery Board, to make very clear its scope is beyond just the A&E department. So looking particularly from the least intensive end of 111, patients accessing advice through the various means of 111, through GP extended hours, urgent treatment, the London Ambulance Service, the trust themselves, and then the discharge process from hospitals back to the patient's home. The Emergency Care Delivery Board is a joint board chaired by our Wandsworth CCG chair, Nicola Jones, and Jacqueline Totterdell, who's the Chief Executive of St George's. And we use that board to look at a number of the transformation initiatives. We've used it to ensure the winter planning has had a real focus and a full governance process. And we also use it to look back at key performance issues. They're also discussed at other meetings, but again, it's another good opportunity to look at the relative pressures in the system from both a commissioning point of view, from a primary care point of view, community health care, mental health care, and then the acute pressures at St George's. The ambulance service also attend that meeting along with NHS England, so all the key players who've got any possible role in urgent and emergency care sit around the table on a regular basis for us to mitigate as far as we possibly can the pressures. And the pressures come particularly, as we know, at winter, but they also come at other periods in the year, bank holidays being perhaps the next most pressured time. So I think Easter is the one that always causes some concern. Patients have to access care in different ways over bank holidays, and we need to make sure that the system in Merton Wandsworth is set up to address that. a principal focus, as I've said, of this board has been on winter planning. So the moment's going to hand over to Sean to talk us through that, but really just wanted to set the scene of the way in which winter has been formally governed and planned for and approached. And Sean will take you through the slides in terms of the way in which winter played out, and the role that Sean in particular and me for a few days spent directly working with St George's to try and mitigate the worst of the demands back in February and March. Not seeing patients, no, but supporting with some of the complex delayed transfers of care and trying to address flow on days when George's were in red and black escalation, and looking into what they could do to improve their bed balance position over those days. Slide 3 just sets out in pictorially the way in which the board reports into the South West London structure and the CCG governance. Again, just to ground this conversation in terms of how we operate. But I'll hand over to Sean. Happy to take any questions at the end about the process of the governance or the board. But I'll hand over to Sean now from slide 4 onwards in terms of the winter review.
Thanks, John. So as John said, so there's 2 hats for the Emergency Care Delivery Board, and these slides are going to focus really on the resilience piece and how we planned and tried to mitigate our way through a very difficult winter. So the process of resilience really is about understanding the expected demand, then planning mitigation for where we know or expect to get shortfalls in capacity. And then essentially what we do in terms of escalation processes where those mitigations aren't enough to meet that shortfall. So as part of the Emergency Care Delivery Board governance in December 2017, the board signed off the demand and capacity modelling that we did, the winter plans that we put together, and essentially as a board highlighted that the risk areas would be in January and February, particularly as John said around the holiday period, so Christmas, New Year, the February half term, and then the respective bank holidays following that. So slide 5 sets out essentially what we did as part of that process. So as I mentioned, we undertook some pretty thorough demand and capacity modelling, and if you look at the appendices, so Appendix 1 is the table which sets out the higher level months and areas in which we expected to have some pinch points. So again, January and February were the 2 months where we anticipated having the biggest problems, and the specialties around medicine where we really expected to have most significant problems. As part of the process, we identified some of the risks, and potentially the biggest risk that stood out was around the elective recovery backlog. As we know, St George's have had problems around that, and what you find in most trusts is that elective activity will be stood down or decreased over the winter period to free up beds, but that was a real bed conflict around St George's and managing that process. We also said that there was a real risk around any kind of extended cold snaps or flu pandemics, because the 2 winters previously we hadn't seen significant levels, and actually if we were to see that over this winter period, that would cause us significant problems. We conducted a series of winter workshops, so we worked with all of our system partners, and I think it's fair to say that in this health economy we have had really good engagement, so we've had really good representation, not only at our Emergency Care Delivery Board meetings themselves, but also as part of the winter workshops that we've done, where we look to essentially come up with a series of mitigations across the system to cover for those periods where we'd have a shortfall in capacity. St George's also developed and implemented a full capacity protocol, which essentially sets out the list of actions that they would take internally during periods of extreme pressure. And what's slightly different to what had been done in previous years was the process of what can be known as boarding patients or sitting patients out, where essentially that means that where there are no beds available within the hospital, where it's fairly certain that a patient will be discharged, the patient could be sat out for up to an hour to essentially allow a patient to be taken out of ED and moved up into a downstream ward. Each of our system partners signed up to something called OPEL, so an operational pressures escalation level, and what that basically did was define what our levels, our threshold levels would be in terms of where we needed to take system action, and each of our organisations across the system also articulated what they would do at those different levels of escalation. and some of those would be around having on-site presence, expediting funding decisions, whether blockages or essentially increasing staff or authorising overtime at short notice. As John said, between John and I, we provided some on-site director level presence at St George's. I think that was just 3 times over the winter period, and essentially that was around trying to unblock any issues or expedite or speed up any processes where there were problems. What we did this year, which we haven't done in other years, so we actually had 3 MAID events, so multi-agency discharge events, and that essentially is around having senior representation from each of our system partners, all congregating on site at St George's, where we were looking to have a real push on increasing discharges before our expected areas, our expected periods of higher pressure. So we did one before Christmas, we did one in February, and we did one in March. And what the numbers showed, actually, following those events, there was actually a significant increase in discharges, which meant that we were going into those challenge periods with a much lower bed occupancy than what we might have had if we hadn't have done those events. So slide 6 just summarises what the data tells us. So if you see in the appendices, there's a selection of graphs there, which is essentially trying to tell the story about what happened over this winter. There is a much more detailed pack if anybody wants, and we can circulate that afterwards. So essentially what that's saying is that performance was lower than expected. So performance was lower than the year before, but also against the planned trajectories. And that, I think it's fair to say, was for St George's, but also across London and nationally as well. Some months in St George's were kind of 4, 5, 6% lower than what we'd seen the year before. Emissions were higher in previous years. Attendances were also up, but probably not to the same extent. Flu infection control, I think it's fair to say, had a really big impact this year compared to previous years. So there were times at St George's where there were kind of 60, 70 beds out of commission and couldn't be used at any one time. And it also made it really difficult for St George's operationally in terms of having to close bays and wards, and obviously that caused the patients then being outlined in wards that they really shouldn't have been in. Availability with staffing was a problem at St George's, but I think that was also seen across South West London as well. I think probably contributed to some of the performance breaches that we've seen. And the bed occupancy levels were higher probably than what we'd expected. So as part of our modelling, we had expected occupancy levels, but with the beds lost to flu, I think we were pretty much running at 100% for quite extended periods during the winter. And the graphs also showed that the formal delayed transfers of care for Merton and Wandsworth remained low throughout the winter, even though the overall delayed transfers of care stayed pretty constant year on year. So slide 7 tries to set out what went well. So I think it's fair to say that clinical staff worked tirelessly across all services over the winter period. I think it's also worth stressing that relationships across Merton and Wandsworth system are really good. So I've been doing this role for a year now, and I've come from other health economies where I think it's fair to say there's some very strained relationships. I think all organisations across Merton and Wandsworth are really committed to getting us through this winter period. I've mentioned the detox and the MAID events. We also did some day of care audits, which essentially they take place during a morning period, and essentially go and look at every patient that's in a bed across the hospital, and with a clinician and administrator then look at whether that patient really needed to be there or whether that patient could have been somewhere else, and then that essentially gives you a snapshot about where patients where the patient delays both internally and externally, and the two that we did basically showed that there were around 20 to 24% of patients that essentially didn't need to be in hospital at any time, which actually adds up to a fairly significant amount of beds. So that was useful in giving us a diagnostic. Some of the new discharge to assess processes and pathways were successful in reducing delays. The system came together during periods of heightened pressure. So as a system, we were probably in black escalation around 8 or 9 times, and I think we had really good engagement from system partners in trying to reduce that pressure. The discharge lounge, I think, has been seen as success in essentially being able to free up patients early in the day. So patients are going down there in the morning period while the kind of the admin around their discharge is being completed, and that's freed up beds earlier in the day. I think there was a real cultural, from I think John might agree, so from being on site at the Trust over the winter period, I think we noted that there was a cultural change at St George's in terms of the staff engagement, a part of their escalation process, and the way that they engaged during black status periods. And 12-hour breaches were kept to a minimum compared to some other health economies and potentially in previous years as well. So slide 8 really sets out what potentially didn't work over the winter period, and I guess are opportunities for next year. So St George's used Caesar Hawkins as a flu ward, and I think it was felt that although it was necessary, it did have an impact on the frail elderly bed capacity and having resources in the right place. St George's have expanded their ambulatory care unit, both in terms of space, staffing and opening hours. That was originally planned to come into effect in October and November, but actually didn't open until the start of March, so we lost some of our mitigation to that. There was a feeling that some of the discharges to care homes didn't really happen early enough in the day, and then sometimes led to failed discharges. And vice versa. Then we also there was a feeling that some of the out of hospital providers were slow in their response to requests for timely assessment and then potential discharges. We had low detox in Merton and Wandsworth, but actually we saw an increase in detox for patients outside of Merton and Wandsworth, and then vice versa. We also struggled to get information about Merton and Wandsworth patients at other hospitals. And the repatriation patients back to other DGH hospitals was actually quite slow, and then sometimes didn't happen, particularly during periods at the height of winter where other trusts were struggling with their own bed capacity. We had quite a few mental health breaches, and some of the analysis we did showed that half of the mental health referrals breached the 4-hour standard, which again is a big area of opportunity for us. And I think it was also fair to say that I think of the 4 12-hour trolley waits that we had, 3 of those were mental health patients and waiting for a mental health bed. And then we also, I think we're not alone, but we also seen some long waits for newer rehab and for patients that had referrals into the Walton and Putney units, which again led to long discharge delays. And then finally on slide 9, so just some learning and some further work. So I think we did have several positives to take away, but I think there's also recognition that there's some learning improvements that we need to make as well. So some of the actions underway, we have refreshed our demand and capacity modelling. So last year we did it in October, we've refreshed it now, so that's we're almost ahead of the game a little bit. And St George's are also doing some work with ESIP around a new demand and capacity model, which potentially may well be rolled out nationally if that's a success. We've already started planning our winter workshops, and again we're kind of well ahead of where we were last year in doing that, and we're currently working our way through a winter checklist. Providers are working and signing up to a new way of working around repatriations, which essentially means that they are committing to take back a repatriation every day. We're looking to work with our CHC contracts and relationships with the councils to improve engagement and the timely assessment in the out-of-hospital sector. There's a London-wide neurorehabilitation capacity piece of work underway to look at how we identify options for patients following the acute phase of their care. And we're also reviewing the role of the Surge Hub and how that operates next winter and going forward. So I suppose just to summarise really, I think that there was a structured whole system approach to this winter, which was really positive. Performance was lower than we expected and planned for, and part of that I think was due to the increased admissions. I think it's really key to point out that the system did respond well in times of escalation, and we reacted as a system and not in isolation. And I think it's fair to say that following the NHSI review, there's now an improvement plan in place and a performance trajectory. And actually, just to highlight, the St George's are now above that trajectory that was agreed, and last week were above 95%, which is a real marked improvement. And just really to reiterate that the planning for 18-19 for winter has started now.
Great.
So any questions?
Thank you very much, Sean. So I suppose the reason why this came to the board was because we kind of look at the kind of high-level performance reports and we think, oh, George's isn't reaching 95%. Well, come on, chivvy along, let's do better. Do you know, there's an immense industry behind it all, and we all assume that doctors and nurses are working really hard, kind of, you know, that's kind of accepted, isn't it? But actually there's an immense amount more that goes into just making the system work. And you know, small things on any given day can tip the system out. And I thought it was really important that the board understood the level of input that we have, you know, even more this year directly as a CCG than we've ever had before. And, you know, Sean and John and, you know, many others have been really very directly involved in a lot of this. So I want to say thank you to them for the work that they do, but also just to make sure that the board is able to ask any questions of Sean and the team, and to consider, you know, next year that we'll probably understand this better when we're thinking about how the performance is. So I think that might be helpful, but really value your, because I chair the A&E delivery board, and, you know, we go through this in fine detail on a kind of regular basis, and it'd be really interesting to have other views on what you're seeing here and what we need to be thinking about further. So I'm going to start with James, and then I'll carry on.
I think I don't have a huge amount to add to what colleagues have said. I mean, I think what is probably worth saying is that we've given an early and actually fairly unfiltered view of how winter's gone. And that this is, you know, we wanted to do it in a quite timely way, really. These are the very active conversations that we're having with partners, including Community Services, Social Care and St George's at the moment. And, you know, these are some of our provisional conclusions, and I think it's fair to say that the Emergency Care Delivery Board's still working through and understanding the root causes and some of what happened here. And, you know, data and insight comes through over a period of time. So it's probably worth just setting that context that it is that fairly unfiltered view. And actually, when we, you know, continue to look at some of these things, you know, when we come back to a winter plan for next year, you won't necessarily see a complete line of sight from the issues that we've identified here to next year's plan, because some of those issues will change materially, or we'll have done some further work and have a different understanding of them. But I think nevertheless it is that useful context, because, you know, now's the time to be doing your winter planning, isn't it? Is it when you don't have these pressures, as John said at the start.
Well, thank you. I'm going to go Josh, then Chris, and then move on. Josh.
So, thank you. So I just wanted to pick out one particular thing from the presentation. So right at the beginning of this process, before last winter, Sean ran a really good workshop which just brought everybody who was interested in this together to basically share what services were already out there. And the good thing about that was that across Merton and Wandsworth there was a lot of shared learning, which I think was one, it showed some of the real benefit of working in that way for things like this. It also some people met each other for the first time in that system, and I think there's learning there for other bits of work that we do. That's putting in that work at the beginning is really important. Yeah. The other thing I just want to say, just with a patient hat on, is I had the misfortune, if you like, to use the services over the winter. Once for me, once for my son. Actually, you know, going to A&E, knowing what I do about the pressure and all the context that we've been talking about, but actually my experience was very smooth. It was obviously busy. We've obviously had a lot to do, but he was very professional and he was very joined up as well. And I think some of the work that Andy's directorate have done on linking up primary care capacity with some of the rest of the system was really useful in making that a really good journey.
Yeah, okay, right, thank you, Josh. Chris, then Mike.
Firstly, can I thank you for this report? It's very concise and I think gives us a rounded view of how the winter went, both its good features and its perhaps more challenging aspect. This may not be in the context of your report, but I think to put a marker down for the performance report, there was, of course, a central direction to suspend elective admissions in order to enable trusts to better weather these winter pressures. So there is, of course, a price to pay from the patient's perspective in elective procedures having been delayed. And obviously part of our responsibilities is to understand all of that as well. My question to you is, was all that necessary in the light of the experience? Did we have to have an absolute priority to these winter pressures at the expense of all elective work?
Shall I? Well, yeah, I'm going to give that one a go. Is that okay? Because I just think that I don't think there was a central diktat to cancel all electives. I think what it was if you are experiencing pressures and you need to cancel elective operations, that will be acceptable by the centre rather than you must cancel all elective operations. That's the first thing. And actually, very few were cancelled across South West London. So that's the other thing is that we didn't need to cancel very many elective operations. Most hospital trusts manage their activity by trying to manage the winter period as well, knowing that it's going to be busier. They do less electives at that period of time, and then they try to do more in the summer period. Obviously, what we have at St George's is a singular problem around referral to treatment and getting that done. So there may have been a few numbers that were added to that, but my view is that we cancelled very, very little. I'm not going to comment on whether or not the national perception was right or not. I think it's right that services need to.
So Chris, I think that is what more you were talking about. There was this, you have to have your bed occupancy has to be. I can't remember what it was, Sean. Maybe it was
85%.
85%. And so that resulted that year, because that was an unexpected move in cancellations that year. That was the year prior.
So that hasn't happened this year.
But this year, what we said was, look, we don't want that to happen again. No. So be planning your. This is about the winter planning worked in that we didn't have to do that, and we said to George's that is not what we want. So plan your bookings more carefully so you're not then cancelling people. It was better.
So am I right in thinking then that we shouldn't expect to see in the performance data evidence of longer delays for elective work? Is that a fair conclusion?
Well, I think we're going to see that anyway with St George's because of the issue that we have around RTT. Okay. So that's going to be the major problem. It will not be because they cancelled lots of operations this winter. There will be a small number, but it will have a little bit of an impact.
It'll be a planned reduction in electives rather than booking than cancellations, which is better, but nevertheless has an impact on waiting times.
Okay, that's fine. Thank you very much.
Yeah, I think it's probably also fair to say that so at St George's there was nothing kind of urgent that was ever cancelled, and the only kind of routine elective operations stood down were kind of the only times would have been during those kind of 9 times that we went into black escalation, and it was almost like a panel process chaired by the chief operating officer to say, actually, do we really want to step this down, or can we find an alternative bed, essentially?
Okay, great, thank you. Mike?
Well, first of all, thank you very much both John to Sean for such a comprehensive report. I do understand, as many of us do, I think some of the huge industries you say that goes on behind the scenes. I want to focus down, if I can, on one really quite specific thing, and that's around the trolley weights and some of the breaches for mental health. I just wanted to ask us as a board whether we're happy that as Associate Commissioners of our Mental Health Service we are that we have the right service specification for liaison psych, and I suppose whether there's anything we can do to help our partners at St George's to improve that. Are there any kind of levers we can use?
So if I can come in on that one, I mean, I think that actually our liaison psych is so it's compliant with the Core 24, the higher end service specification, and we've been ahead of many other areas in funding that, and I actually think the liaison psych works very well. The problem that we have is around what happens after liaison psych. So we know that there's significant complexity around patients who have been seen by liaison psych and what happens to them afterwards. Either they need a bed or they need some ongoing care, and that's not potentially available within, say, a 12-hour window or within a reasonable window. So particularly if somebody presents at the start of the night, then getting them that onward care, the support to be discharged home or into another bed. We also know that for St George's there are specific issues around the borders between mental health provision as well. So although we pick up quite a lot of South West London patients where we've got certain arrangements and we've got the psychiatric decision unit at Springfield, albeit that can, that has a finite amount of capacity as well. We also pick up patients who come in from north of the river, and we also pick up patients who are in the South East London, so the South London and Maudsley catchment. So for me, the issue has not actually been about the site liaison, but what we're looking at is, what need to be the downstream services, and so that's really the issue that we're looking at now. And I think it is a fair challenge to say, how do we continue to explore what capacity and capability do we need in there, and looking at particularly the 12-hour breaches, what were the services where we struggled to get somebody's follow-on provision in a timely way. That's not just a St George's issue though, and I think that's been observed with a number of patients in a number of the A&Es, so we're picking it up as a system.
Good, thank you. I'm going to move on because quite a lot of people want to say things. Carol.
Thank you for the report. Very useful. My question is, to what extent is transport a really important factor in this? It's the care home discharges, not getting to the care homes in time for them to be readmitted at home, and use of the discharge lounge. I have several very elderly neighbors and friends who spent 3 or 4 hours in discharge lounges over this period, waiting for transport to get home and eventually arrive back at their sheltered housing or whatever, 10 o'clock at night. So could, an emergency escalation for transport arrangements be looked at?
Yeah, and as part of the Windsor Review, transport did come up as an area of improvement for next year. So you're right that there were issues around transport. I think for St George's in particular, it's because obviously they're a tertiary centre and they specialise in quite a few different things. They get patients that can come from quite far away, and having been on site, and John will probably echo this, that there were kind of times where there were 2 or 3 patients that had some really long trips home. So like potentially going back to Manchester and places like that, and I think the learning that came out of that, if there were 2 or 3 kind of long travelling patients that actually had quite a big impact on their transport home on a regular basis. And a lot of the conversation was about and the learning about how they can discharge early in the day does all link to their transport and the way that's organised. So it is a big area of opportunity, I think, for next winter.
Okay, thank you. Stephen.
It's really an observation. I mean, I welcome very much the work that was done in the winter and all the rest of it. But what this is describing is a system under vast stress and absolutely on the knife edge. I mean, because what you said is that the actual demands last winter were less than expected. There was flu, but it wasn't, the worst flu you could ever have. And we just about came through all right, despite everybody, including people around this table, personally spending, disproportionate amount of time and energy. So I guess in terms of the learning and further work, I mean, I welcome everything that you're doing and so on. I mean, it's all excellent, but I'm left with a sort of feeling, going back to the sort of more strategic perspective. I mean, this is not a happy situation to be in, and winter is not an exception. Winter is not some strange thing that hits us. We do have winter, and winter seems to get longer each year as well. So there's another take on all this, which is everybody is absolutely working their socks off to make the best of what we can do, and everything that you're doing is excellent and fine, and do more of it. But actually, that is not the answer. The answer has to be something else if we are interested in sustainability. And I'm not quite sure the vehicle for addressing that and actually saying what do we really need to do to get to a sustainable position rather than try and struggle through each winter by the skin of our teeth at best.
So just on this issue then, so Sarah. Yeah.
So I think you're absolutely right, and I think transformation of the system, because this is not about A&E. I mean, this is about A&E, what we're talking about now, but actually the answer does not lie in A&E. The answer lies in how we develop our local health and care plans, about how we look at transformation across the piece and support people differently in the community, so that those with long-term conditions aren't having to go into a hospital in order to receive their care and all of those things. And I think we're on that journey. I think that in the meantime, whilst we are still doing that work, we still have to make sure that the services that we have can deliver when we have peaks and troughs in demand. And that is not just at the winter, it's in the summer as well. Can I say in some areas it's busier in the summer than it is in the winter. It's about making sure that we manage our system in the very best way we possibly can at those times, whilst we're still transforming the system. So we're kind of knitting it whilst we're wearing the jumper. But that's the only way we can do it, I think, as a system.
Well, in that case, we need to link this conversation to the earlier conversation. And one of the questions is, will this LTB, sorry, whatever it was called, whatever your plan is called, will it actually answer that question? Because it needs to.
Go answer that now, Josh. It just needs to. It just needs to. Thank you. John?
As Sarah's mentioned, the transformation, absolutely. We've got to look at having people being cared for in the least intensive environments. So some of those patients at George's who become incredibly long delayed transfers of care, there's a very, very small number of them, but they use a number of bed days during their stay. So there's something about going forward for next year, looking at what more we can do to absolutely expedite those. We also look at what we call stranded and super stranded patients, those over 7 days and 21 days. So what more we can do to bring the proportion of those down. At the moment, that's a very small percentage of occupancy at George's, but in the winter, that exponentially increases. So what more we can do to stop that. But the transformation agenda, absolutely, where we look at what NHS England call channel shift, but moving people to the least restrictive, the least intensive area of care possible, so that George's do have beds on those challenge days of winter for those acutely ill patients who need it. I think the other bit of learning is around what more proactively can be done around care planning, etc., so that all of that is in place for those cohorts of patients where that's beneficial, again, ahead of the winter, and they're not being developed in the midst of the winter.
Yeah. So, and sort of just to add into the mix here, there's an awful lot of work going on ambulatory care, so that, it used to be the case that people were admitted for a week for something, whereas now they're in for a few hours and they come home again. So, care's really shifting already from that point of view, and we're doing a lot of work with George's on their ambulatory care pathways. So that also contributes. I think there's one thing that, when there's pressure in the system to reduce length of stay, one of the consequences of that can be readmissions. And I think we don't really talk about that very much. And I think it would be really useful to see what the consequences of some of this activity is at some point. So I'm sure that's being looked at somewhere, but it might be something that we want to kind of flag here. So I'm going to go now. It's got Sam, Rue, then Huda, and then no more hands, please. Sam.
Yes, thank you. Just on that point and around readmission, and I'm sure there is work going on around CHC and discharge to assess, and getting it right first time in terms of that discharge, and I'm sure that's part of the sort of planning going forward. I just wanted to say that I think the level of support in the acute at this times, and having, like many of us, sort of been in these positions in week 2 in January, is really, really important for the relationship with the hospital, for brokerage in terms of the relationships across the system. I think that's incredibly positive, and this is really, really helpful overview of all of that. Thank you.
Thank you. Rui.
So, and I'll just say quickly, so I think Jacqueline Toftal was on several occasions has thanked the wider system, just to say that they were kind of indebted to the support they got over the winter period.
Yeah. Thank you. Yeah.
It was just 2 points. Well, ambulatory care pathways you mentioned, but also Mike's point about mental health crises. There are now 2 recovery cafes which have started in year, which are meant to deal with these crises. So it'll be interesting to see how that helps. I've had 2 patients who fared really well and been avoided going into ED.
Good. Huda.
This is a perspective from my social services colleagues. I didn't want to go last because it's got a slightly less positive picture to partners, but Liz, the Director of Social Services, wanted to highlight that, first of all, the positive bit, worked really well this year together, the partnership approach, etc. But the focus on performance has increased cost and put pressure on social services budgets. And also the market out there, the provider market, is very challenged both in terms of capacity and capability. And this is hasn't been, as you said before, it hasn't been an atypical year, like a winter with pressure, etc. So, and Liz's view that social care will require more sustainable funding to kind of be able to cope in an ever challenging system. But this is not a criticism of the work we've been doing together, because we've worked very well together on this.
No, thank you. Good. Okay. Yeah, okay.
So I think in the NHS we recognise that actually sustainable funding for social care would be something that we would also support social care in getting as well from national. So we do recognise the impact, and it has a massive impact on us as well when the care home community cannot respond to the pressures that are coming, because basically those people then sit in hospital. So it's really, really important that we get that right, and my view is that we would all be behind local authorities difficulties in making that argument. And I think generally the NHS has been, even nationally. I think Simon Stevens has been quite clear that, you know, funding to social care is needed in order to make the NHS work. So I think we're all behind that position. Yeah.
Good. Excellent. Thank you. Okay, let's just wrap up then. So I think, you know, we probably feel more informed now about what goes on with the winter planning and the support that we give to the system as commissioners over the winter. And thank you to Sean and John and all the people behind the scenes who do all of that work, because there's an immense amount. You know, the planning for this winter has already started, hasn't it? We're already in train with that, and we'll continue to keep that under review through the A&E Emergency Care Delivery Board. So, Sean, thank you very much for coming. Make your exit before you get all the rest of this. Thank you. Fab. Thank you very much. Right, so we're going on. What we've got, executive report now. So, James, anything you wanted to particularly highlight?
No, I'm happy to take as read and take any questions.
Any questions? Cool, thank you. John, on performance report, any highlights or lowlights or anything you wanted to say?
I think just very briefly, just a couple of highlights. Otherwise, I'll take the report as read and happy to take any questions. Just building off the back of the previous conversation about winter, so in terms of where we are with the A&E position at the moment, we've had a very good beginning to the year. George's agreed a trajectory, as all trusted, for the year, which required them to achieve 88% performance in April, 91% in May. They've exceeded those two targets in the first 2 months of the year, which is very positive to see. And the 15-point action plan that underpins their current approach to A&E performance seems to be delivering, and we're beginning to get some insight into the metrics that sit underneath those 15 points, and we'll continue to work with them to understand the way in which each of those 15 quite disparate pieces of work are playing out over the year. There are some concerns about a couple of them where they're immediately off target, but nevertheless the headline performance is exactly where it needs to be at this point in time, which is really positive to see. In terms of RTT, which is the other significant challenge, the core recovery plan has at its core the staff training. We know that the PTLs that have recently been established can easily be corrupted by poor data. So at the moment, there's ongoing challenge of releasing staff, continuing to work with staff who make the most errors in their data input, and a commitment now that training is mandated, so that the team will undergo the training to significantly reduce the error rate. St George's are now beginning to develop a plan to return to national waiting times reporting, and they've shared the first iteration of that with NHSI as their regulator. That's the very beginning of a process now. Commissioners will be fully involved in terms of reviewing and supporting George's to get back to national reporting. And I think our ongoing focus now is on waiting times at specialty level and understanding the demand and capacity planning, which remains ongoing to get back to a sustainable position against all specialties.
Any questions on that report? John, thank you very much. Now we've got some summary minutes to note from Finance Committee in Common, Integrated Governance Quality Committee, Audit Committee, and the Committee for Collaborative Decision Making, which Carol chaired. That was way back in March. Some of these are quite old now, so probably news past really, but anything anyone wanted to raise? No, very good. Okay, so we've got any other business unless some has arisen since I asked. And then a little time for some open space. If anybody has any questions that you'd like to ask, yes. Please do, yeah. Oh, yes, would you? Yeah, no, do, yeah, that'd be great. We could do with that at this time. Yeah, switch it on.
I believe at the last meeting there was some concern about the number of patients in the borough being service by Chelsea and Westminster Hospital, and I wondered if that was a trend, what the data you had on that, and why it's a problem and what you're doing about it if it is a problem.
James,
Yeah, I'll respond to that.
just explain the context, because in here people don't know.
Yeah, so I think that we were, if I recall rightly, we were looking at the acute activity reports for the year, and we were looking at the variances that we'd seen year on year and variances to our plan. And our plan set basically on the previous year's activity in terms of the number of people going to St George's and how much it costs to treat them, and the number of people going to Chelsea and Westminster and how much it costs to treat them. So I don't have figures to hand, but we have seen an increase in patients going to Chelsea and Westminster. I think that there's a number of causes for this. I think one of them we've just been talking about, which is the ongoing elective care access issues at St George's. So at the moment St George's aren't reporting their waiting times, and we know that there are relatively longer waiting times at St George's in certain specialties. Clearly, if you live in an area of the borough that's accessible to Chelsea and Westminster, because we've been supporting GPs to provide that information to patients about the relative waiting times, if you want to be seen more quickly, you may choose to go to Chelsea and Westminster, and we think that's a significant driver behind that. I personally don't feel it's problematic. I think that we have a principle of patient choice in the NHS, and I think that's really important. I think we need to stand behind that. I think in the long term, St George's would like to be able to treat patients for whom they are the local hospital, but they need to demonstrate to us and to GPs and patients that they're able to see patients in a timely way, and therefore kind of in a way win back that patient flow in the longer term. So I don't see it as problematic. I think we should get patients into an appropriate and high quality and accessible service. At the moment, sometimes that's more often Chelsea and Westminster for some areas than it is St George's, but that trend might change as St George's begin to tackle some of the challenges they have. So I don't think it's problematic. One of the things that we have also flagged and that we're working on is strengthening our relationships as a South West London system with our colleagues in North West London, so that we can, if we've got, say, any quality or access concerns, or we want to give some feedback to Chelsea and Westminster, that we're able to use those routes to give feedback. So no, not a problem, and something we're working with.
A financial problem there?
No, because we pay for that activity, whether it's treated at St George's or at Chelsea and Westminster. We will pay for wherever the patient has gone.
So it's not a financial problem for us. I think St George's would prefer to have that activity in-house, because obviously that's less money for them that they could have. So that's why it's important to them that they clear their backlog and that they start to provide appointments in a timely way, so that they will get that activity coming through St George's.
Thank you very much. Just one more question, just the last one. I looked at this report which you sent out, which you call it the stakeholder survey, and I was rather disappointed to see that only 30 out of 40, I think it was, GPs responded. What's the percentage of the patient population is that represented?
So it would be difficult to know, because it could be that all of the small practices responded and none of the large ones, or vice versa. So I don't know offhand. We could have a look at that. But I think that's a fantastic response rate.
Yeah. It's really good.
It's really excellent.
It benchmarks very well.
Yeah.
I'm sure you're right, but it seemed to me that if the bigger practices didn't respond.
So we will know. I just don't have it in front of me.
No, we don't know. So we don't know because it's anonymised.
Oh, okay.
So we don't actually know who responded. So we can't tell you what percentage of the population it is. But it benchmarks really well. The percentage of responses that we have had in Wandsworth is much higher than the national average. So actually it is voluntary, and it comes through externally. It doesn't come from us. It comes through from an external body. And if they're very busy, they don't have time to fill it in. again. So I don't necessarily think it's a reflection that they're not engaged with the CCG or that they have any negative views of the CCG. It's just that the percentage that have had the time to respond have, and they've responded very positively. My view is that if you had some that felt very, very negatively, they make the time to respond. So I don't see it as a major issue. In fact, I think, again, a high response rate actually compared to others.
Yeah, but if it's an average, then it'd be about 75% of patients of our 380,000 patients that had a GP from their practice respond.
How do you feel about 70% of them only, i.e. 30% of them didn't feel they had the opportunity to influence these?
So, I mean, I think we talked about that a bit. It's partly from so I think there's always the same issue from patients or GP practices or our partners and stakeholders is, people would always like more say in what happens. And I think that's one of the things that we want to make sure is that people are not only informed about what's going on, but they get the opportunity to comment, influence and be involved in how we make decisions about healthcare. So I think that it's good that we know that that's what some people think, and it's something that will definitely be part of how we manage the next year and focus on. Good. Excellent. Okay, anything else from anyone? No. Thank you very much. So thank you very much, everyone. Worked very hard this morning. We've got a very brief part 2 to follow, so if people could vacate the room